Hello again, Jared Pitts here, and today we're going to be looking at another article by Dr. Ray Peat. This one is called TSH, Temperature, Pulse Rate, and Other Indicators in Hypothyroidism. So, if there is a subject with just an incredible amount of misinformation, disinformation, redirection, I don't know what you want to call it, but, thyroid and metabolism, it is off the charts with this topic. So, happy to be reading this one by Dr. Ray Peat. You can find this on his website, raypeat.com, under the articles section. And hopefully this will help you in your journey. Again, so much misinformation out there. And if you go through this, I am positive you will learn more about the thyroid and our metabolism and better indicators than what is typically used to figure out if you're hypo, hyper, whatever, thyroid. Better indicators that you can do at home. And, this is not, I'm not a doctor. I'm not advising, suggesting. This is Dr. Peat's research, and I'm helping to get it out there to the general public. And hopefully you learn something. This is how it goes. Each of the indicators of thyroid function can be useful, but has to be interpreted in relation to the physiological state. Increasingly, TSH, or the pituitary thyroid stimulating hormone, has been treated as if it meant something independently. However, it can be brought down into the normal range or lower by substances other than the thyroid hormones. Quote-unquote basal body temperature is influenced by many things besides thyroid. The resting heart rate helps to interpret the temperature. In a cool environment, the temperature of the extremities is sometimes a better indicator than the oral or eardrum temperature. The basal metabolic rate, especially if the rate of carbon dioxide production is measured, is very useful. The amount of water and calories disposed of in a day can give a rough idea of the metabolic rate. The T wave on the electrocardiogram and the relaxation rate on the Achilles reflex test are useful. And I believe on my other thyroid video, another Ray Peat article, it talks about this Achilles reflex test. And I believe I posted a couple of videos there, so check it out. I think you'll enjoy those and find something useful. Blood tests for cholesterol, albumin, glucose, sodium, lactate, total thyroxine, and total T3 are useful to know because they help to elevate the present thyroid status, and sometimes they can suggest ways to correct the problem. Okay, so there are some blood tests that can be helpful. Less common blood or urine tests, adrenaline, cortisol, ammonium, free fatty acids, if they are available, can help to understand compensatory reactions to hypothyroidism. A book such as McGavick's The Thyroid, that provides traditional medical knowledge about thyroid physiology, can help to dispel some of the current dogmas about the thyroid. Using more physiologically relevant methods to diagnose hypothyroidism will contribute to understanding its role in many problems now considered to be unrelated to the thyroid. Okay, now we're going to get into the main bulk of this article. I have spoken to several people who told me that their doctors had diagnosed them as, quote-unquote, both hypothyroid and hyperthyroid. Although physicists can believe in things which are simultaneously both particles and not particles, I think biology, and medicine as far as it is biologically based, should occupy a world in which things are not simultaneously themselves and their opposites. Those illogical, impossible diagnoses make it clear that the rules for interpreting test results have in some situations lost touch with reality. Until the 1940s, hypothyroidism was diagnosed on the basis of signs and symptoms, and sometimes the measurement of oxygen consumption, known as the basal metabolic rate, was used for confirmation. Besides the introduction of supposedly quote-unquote scientific blood tests, such as the measurement of protein-bound iodine, or PBI, in the blood, which I believe the other thyroid article covers more in depth than this one, there are other motives for becoming parsimonious with the diagnosis of hypothyroidism. With the introduction of synthetic thyroxine, one of the arguments for increasing its sale was that natural armor thyroid, which was precisely standardized by biological tests, wasn't properly standardized, and that an overdose could be fatal. A few articles in prestigious journals created a myth of the danger of thyroid, and the synthetic thyroxine was falsely said to be precisely standardized, and to be without the dangers of the complete glandular extract. Between 1940 and about 1950, the estimated percentage of hypothyroid Americans went from 30% or 40% to 5% on the basis of the PBI test. And it has stayed close to that lower number, and in parentheses we have many publications claim it to be only 1 or 2%. By the time that the measurement of PBI was shown to be only vaguely related to thyroid hormonal function, it had been in use long enough for a new generation of physicians to be taught to disregard the older ideas about diagnosing and treating hypothyroidism. They were taught to inform their patients that the traditional symptoms that were identified as hypothyroidism before 1950 were the result of the patient's own behavior. Sloth and gluttony, for example, which produced fatigue, obesity, and heart disease. Or that the problems were imaginary. And in parentheses, we have women's hormonal and neurological problems, especially. Or that they were simply mysterious diseases and defects. And in parentheses, we have recurring infections, arthritis, and cancer, for example. As the newer, more direct tests became available, their meaning was defined in terms of the statistical expectation of hypothyroidism that had become an integral part of medical culture. To make the new TSH measurements fit the medical doctrine, an 8 or 10-fold variation in the hormone was defined as quote-unquote normal, with any other biological measurement, such as erythrocyte count, blood pressure, body weight, or serum sodium, calcium, chloride, or glucose, a variation of 10 or 20% from the mean is considered to be meaningful. If the doctrine regarding the 5% prevalence of hypothyroidism hadn't been so firmly established, there would have been more interest in establishing the meaning of these great variations in TSH. In recent years, the quote-unquote normal range for TSH has been decreasing. In 2003, the American Association of Clinical Endocrinologists changed their guidelines for the normal range to 0.3 to 3 micro-IU per milliliter. But even though this lower range is less arbitrary than the older standards, it still isn't based on an understanding of the physiological meaning of TSH. Over a period of several years, I never saw a person whose TSH was over 2 micro-IU per milliliter who was comfortably healthy, and I formed the impression that the normal or healthy quantity was probably something less than 1. If a pathologically high TSH is defined as normal, its role in major diseases such as breast cancer, myalgia, MS, fibrotic diseases, and epilepsy will simply be ignored. Even if the possibility is considered, the use of an irrational norm instead of a proper comparison, such as the statistical difference between the mean TSH levels of cases and controls, leads to denial of an association between hypothyroidism and important diseases, despite evidence that indicates an association. Some critics have said that most physicians are, quote-unquote, treating the TSH rather than the patient. If TSH is itself pathogenic because of its pro-inflammatory actions, then that approach isn't entirely useless, even when they, quote-unquote, treat the TSH with only thyroxine, which often isn't well converted into the active triiodothyronine, or T3. But the relief of a few symptoms in a small percentage of the population is serving to blind the medical world to the real possibilities of thyroid therapy. TSH has direct actions on many cell types other than the thyroid, and probably contributes directly to edema. And that's from a study by Wheatley and Edwards in 1983. Fibrosis and mastocytosis. If people are concerned about the effects of a TSH deficiency, then I think they have to explain the remarkable longevity of the animals lacking pituitaries in W.D. Denkla's experiments, or of the naturally pituitary deficient dwarf mice that lack TSH, prolactin, and growth hormone, but live about a year longer than normal mice, and that's from a study in 2003. Until there is evidence that very low TSH is somehow harmful, there is no basis for setting a lower limit to the normal range. Some types of thyroid cancer can usually be controlled by keeping TSH completely suppressed. Since TSH produces reactions in cells as different as fibroblasts and fat cells, pigment cells in the skin, mast cells, and bone marrow cells, there's a study from '99, it won't be surprising if it turns out to have a role in the development of a variety of cancers, including melanoma. Many things, including the liver and the senses, regulate the function of the thyroid system, and the pituitary is just one of the factors affecting the synthesis and secretion of the thyroid hormones. A few people who had extremely low levels of pituitary hormones and were told that they must take several hormone supplements for the rest of their life began producing normal amounts of those hormones within a few days of eating more protein and fruit. Their endocrinologist described them as effectively having no pituitary gland. Extreme malnutrition in Africa has been described as creating, and here's a quote, a condition resembling hypophycectomy. There's a study from 1975. But the people I talked to in Oregon were just following what they thought were healthful nutritional policies, avoiding eggs and sugars and eating soy products. Ay, ay, ay. Occasionally, a small supplement of thyroid in addition to a good diet is needed to quickly escape the stress-induced hypophycectomized condition. And since I was not sure what hypophycectomized means, I went ahead and looked it up, and it is a surgery. Hypophycectomy, right, is a surgery to remove the pituitary gland. So that's what it means when it says hypophycectomized condition. There you go. Aging, infection, trauma, prolonged cortisol excess, somatostatin, dopamine or L-dopa, adrenaline sometimes, Manisto et al. 1979, so there's a study reference there, amphetamine, caffeine, and fever can lower TSH. Alright, so a lot of things. Apart from the effect of feedback by the thyroid hormones, creating a situation in which TSH can appear normal or low at the same time that there is real hypothyroidism. A disease or its treatment can obscure the presence of hypothyroidism. Parkinson's disease is a clear example of this. And here's a study. And a quote says, in the same way hypothyroidism can stimulate Parkinson's disease, the latter can also conceal hypothyroidism. The stress-induced suppression of TSH and other pituitary hormones is reminiscent of the protective inhibition that occurs in individual nerve fibers during dangerously intense stress, and might involve such a quote-unquote parabiotic process in the nerves of the hypothalamus or other brain region. The relative disappearance of the pituitary hormones when the organism is in very good condition, for example the suppression of ACTH and cortisol by sugar or pregnenolone, is parallel to the high energy quiescence of individual nerve fibers. These associations between energy state and cellular activity can be used for evaluating the thyroid state, as in measuring nerve and muscle reaction times and relaxation rates. For example, relaxation, which is retarded because of slow restoration of the energy needed for cellular quote-unquote repolarization, is the basis for the traditional use of the Achilles tendon reflex relaxation test for diagnosing hypothyroidism. The speed of relaxation of the heart muscle also indicates thyroid status. And there's a study from 1996 there. Stress, besides suppressing the TSH, acts in other ways to suppress the real thyroid function. Cortisol, for example, inhibits the conversion of T4 to T3, which is responsible for the respiratory production of energy and carbon dioxide. Adrenaline, besides leading to increased production of cortisol, is lipolytic, releasing the fatty acids which, if they are polyunsaturated, inhibit the production and transport of thyroid hormone, and also interfere directly with the respiratory functions of the mitochondria. Adrenaline decreases the conversion to T4 to T3 and increases the formation of the antagonistic reverse T3. And that's from a couple of studies. During the night at the time adrenaline and free fatty acids are at their highest, TSH usually reaches its peak. TSH itself can produce lipolysis, raising the level of circulating free fatty acids. This suggests that a high level of TSH could sometimes contribute to functional hypothyroidism because of the anti-metabolic effects of the unsaturated fatty acids. These are the basic reasons for thinking that the TSH test should be given only moderate weight in interpreting thyroid function. The metabolic rate is very closely related to thyroid hormone function, but defining it and measuring it have to be done with awareness of its complexity. The basal metabolic rate that was commonly used in the 1930s for diagnosing thyroid disorders was usually a measurement of the rate of oxygen consumption, made while lying quietly early in the morning, without having eaten anything for several hours. When carbon dioxide production can be measured at the same time as oxygen consumption, it's possible to estimate the proportion of energy that is being derived from glucose, rather than fat or protein, since oxidation of glucose produces more carbon dioxide than oxidation of fat does. Glucose oxidation is efficient and suggests a state of low stress. The very high adrenaline that sometimes occurs in hypothyroidism will increase the metabolic rate in several ways, but it tends to increase the oxidation of fat. If the production of carbon dioxide is measured, the adrenaline/stress component of metabolism will be minimized in the measurement. When polyunsaturated fats are mobilized, their spontaneous peroxidation consumes some oxygen, without producing any usable energy or carbon dioxide. So this is another reason that the production of carbon dioxide is a very good indicator of thyroid hormone activity. The measurement of oxygen consumption was usually done for 2 minutes, and carbon dioxide production could be accurately measured in a similarly short time. Even a measurement of the percentage of carbon dioxide at the end of a single breath can give an indication of the stress-free thyroid hormone stimulated rate of metabolism. It should approach 5 or 6% of the expired air. Increasingly, in the last several years, people who have many of the standard symptoms of hypothyroidism have told me that they are hyperthyroid, and that they have to decide whether to have surgery or radiation to destroy their thyroid gland. They have told me that their symptoms of hyperthyroidism, according to their physicians, were fatigue, weakness, irritability, poor memory, and insomnia. They didn't eat very much, they didn't sweat noticeably, and they drank a moderate amount of fluids. Their pulse rates and body temperature were normal, or a little low. Simply on the basis of some laboratory tests, they were going to have their thyroid gland destroyed. But on the basis of all the traditional ways of judging thyroid function, they were hypothyroid. Broda Barnes, who worked mostly in Fort Collins, Colorado, argued that the body temperature measured before getting out of bed in the morning was the best basis for diagnosing thyroid function. Fort Collins, at a high altitude, has a cool climate most of the year. The altitude itself helps the thyroid to function normally. For example, one study from Savory et al. 1998 showed an 18% increase in T3 at a high altitude, and mitochondria became more numerous and more efficient at preventing lactic acid production, capillary leakiness, etc. In Eugene, during a hot and humid summer, I saw several obviously hypothyroid people whose temperature seemed perfectly normal. And I'm not sure what that is supposed to say there. It's probably going to come to me later, but it looks like euthyroid by Barnes standards. All right, talking about Broda Barnes. But I noticed that their pulse rates were in several cases very low. It takes very little metabolic energy to keep the body at 98.6 degrees when the air temperature is in the 90s. In cooler weather, I began asking people whether they used electric blankets and ignored their temperature measurements if they did. The combination of pulse rate and temperature is much better than either one alone. I happened to see two people whose resting pulse rates were chronically extremely high despite their hypothyroid symptoms. Then they took a thyroid supplement and their pulse rates came down to normal. Healthy and intelligent groups of people have been found to have an average resting pulse rate of 85 per minute, while less healthy groups average close to 70 a minute. The speed of the pulse is partly determined by adrenaline, and many hypothyroid people compensate with very high adrenaline production. Knowing that hypothyroid people are susceptible to hypoglycemia and that hypoglycemia increases adrenaline, I found that many people had normal and sometimes faster than average pulse rates when they woke up in the morning and when they got hungry. Salt, which helps to maintain blood sugar, also tends to lower adrenaline, and hypothyroid people often lose salt too easily in their urine and sweat. Measuring the pulse rate before and after breakfast and in the afternoon can give a good impression of the variations in adrenaline. The blood pressure, too, will show the effects of adrenaline in hypothyroid people. Hypothyroidism is a major cause of hypertension. Both hypoglycemia also tends to decrease the conversion of T4 to T3. So heat production, sorry, I think I said both, but anyway, hypoglycemia also tends to decrease the conversion of T4 to T3. So heat production often decreases when a person is hungry. First, their fingers, toes, and nose will get cold because adrenaline, or adrenergic sympathetic nervous activity, will increase to keep the brain and heart at a normal temperature by reducing circulation to the skin and extremities. Despite the temperature regulating effect of adrenaline, the reduced heat production resulting from decreased T3 will make a person susceptible to hypothermia if the environment is cool. Since food, especially carbohydrate and protein, will increase blood sugar and T3 production, eating is thermogenic and the oral or eardrum temperature is likely to rise after eating. Blood sugar falls at night, and the body relies on the glucose stored in the liver as glycogen for energy, and hypothyroid people store very little sugar. As a result, adrenaline and cortisol begin to rise almost as soon as a person goes to bed, and in hypothyroid people, they rise very high, with the adrenaline usually peaking around 1 or 2 a.m., and the cortisol peaking around dawn. The high cortisol raises blood sugar as morning approaches and allows adrenaline to decline. Some people wake up during the adrenaline peak with a pounding heart and have trouble getting back to sleep unless they eat something. If the nighttime stress is very high, the adrenaline will still be high until breakfast, increasing both temperature and pulse rate. The cortisol stimulates the breakdown of muscle tissue and its conversion to energy, so it is thermogenic, for some of the same reasons that food is thermogenic. So this is talking about cortisol breaking down muscle tissue, right? Whereas adrenaline is going to break down fatty tissue. So from what I understand, that's, those two and what they will break down for fuel, right? Okay. After eating breakfast, the cortisol and adrenaline, if it stayed high despite the increased cortisol, will start returning to a more normal, lower level as the blood sugar is sustained by food instead of by the stress hormones. In some hypothyroid people, this is a good time to measure the temperature and pulse rate. In a normal person, both temperature and pulse rate rise after breakfast, but in very hypothyroid people, either or both might fall. Some hypothyroid people have a very slow pulse, apparently because they aren't compensating with a large production of adrenaline. When they eat, the liver's increased production of T3 is likely to increase both their temperature and their pulse rate. By watching the temperature and pulse rate at different times of day, especially before and after meals, it's possible to separate some of the effects of stress from the thyroid-dependent, relatively basal metabolic rate. When beginning to take a thyroid supplement, it's important to keep a chart of these measurements for at least 2 weeks, since that's roughly the half-life of thyroxine in the body. When the body has accumulated a steady level of the hormones and began to function more fully, the factors such as adrenaline that have been chronically distorted to compensate for hypothyroidism will have begun to normalize, and the early effects of the supplementary thyroid will, in many cases, seem to disappear, with heart rate and temperature declining. The daily dose of thyroid often has to be increased several times as the state of stress and the adrenaline and cortisol production decrease. Counting calories achieves approximately the same thing as measuring oxygen consumption, and is something that will allow people to evaluate the various thyroid tests that may be given by their doctor. Although food intake and metabolic rate vary from day to day, an approximate calorie count for several days can often make it clear that a diagnosis of hyperthyroidism is mistaken. If a person is eating only about 1,800 calories per day and has a steady and normal body weight, any quote-unquote hyperthyroidism is strictly metaphysical, or as they say, quote-unquote clinical. When the humidity and temperature are normal, a person evaporates about a liter of water for every 1,000 calories metabolized. Eating 2,000 calories per day, a normal person will take in about 4 liters of liquid and form about 2 liters of urine. A hyperthyroid person will invisibly lose several quarts of water in a day, and a hypothyroid person may evaporate a quart or less. When cells, because of low metabolic rate, don't easily return to their thoroughly energized state after they have been stimulated, they tend to take up water, or in the case of blood vessels, to become excessively permeable. Fatigued muscles swell noticeably, and chronically fatigued nerves can swell enough to cause them to be compressed by the surrounding connective tissues. The energy and hydration state of cells can be detected in various ways, including magnetic resonance and electrical impedance, but functional tests are easy and practical. With suitable measuring instruments, the effects of hypothyroidism can be seen as slowed conduction along nerves and slowed recovery and readiness for new responses. Slow reaction time is associated with slowed memory, perception, and other mental processes. Some of these nervous deficits can be remedied slightly just by raising the core temperature and providing suitable nutrients, but the active thyroid hormone T3 is mainly responsible for maintaining the temperature and nutrients and the intracellular respiratory energy production. In nerves, as in other cells, the ability to rest and repair themselves increases with a proper level of thyroid hormone. In some cells, the energized stability produced by the thyroid hormones prevents inflammation or an immunological hyperactivity. In the 1950s, shortly after it was identified as a distinct substance, T3 was found to be anti-inflammatory, and both T4 and T3 have a variety of anti-inflammatory actions, besides the suppression of the pro-inflammatory TSH. Because of the actions of T3 can be inhibited by many factors, including polyunsaturated fatty acids, reverse T3, and excess thyroxine, the absolute level of T3 can't be used by itself for diagnosis. Quote-unquote free T3 or quote-unquote free T4 is a laboratory concept, and the biological activity of T3 doesn't necessarily correspond to its quote-unquote freedom in the test. T3 bound to its transport proteins can be demonstrated to enter cells, mitochondria, and nuclei. Transthyretin, which carries both vitamin A and thyroid hormones, is sharply decreased by stress and should probably be regularly measured as part of the thyroid examination. When T3 is metabolically active, lactic acid won't be produced unnecessarily, so the measurement of lactate in the blood is a useful test for interpreting thyroid function. Cholesterol is used rapidly under the influence of T3, And ever since the 1930s, it has been clear that serum cholesterol rises in hypothyroidism and is very useful diagnostically. Sodium, magnesium, calcium, potassium, creatinine, albumin, glucose, and other components of the serum are regulated by the thyroid hormones and can be used along with the various functional tests for evaluating thyroid function. Stereotypes are important. When a very thin person with high blood pressure visits a doctor, hypothyroidism isn't likely to be considered. Even high TSH and very low T4 and T3 are likely to be ignored because of the stereotypes. And if those tests were in the healthy range, the person would be at risk for the hyperthyroid diagnosis. But remembering some of the common adaptive reactions to a thyroid deficiency, the catabolic effects of high cortisol, and the circulatory disturbance caused by high adrenaline should lead to doing some of the appropriate tests instead of treating the person's hypertension and quote-unquote undernourished condition. All right. Fantastic article. Really enjoyed that one. Learned some new words. And I hope you all learned some new things. Definitely something to come back to and reference as far as the tests that he's talking about taking. And hope you guys have a fantastic Thanksgiving. If you're in America tomorrow, I'm excited to consume some fantastic food with the fam. You guys have a good one, and I will see you next time.